Welcome, everybody. Today we have Dr. Morgan, and Dr. Morgan is going to talk about knee osteoarthritis. Dr. Morgan, welcome.
Hi, thank you. Thank you for having me here. So I am Dr. Ryan Morgan, an orthopedic surgeon at Glendale Adventist. And I am a knee surgeon as well as shoulder surgeon. I did a sports medicine fellowship. So that means I did extra training in shoulder and knee surgery and take care of a lot of sports injuries, but also take care of a lot of osteoarthritis, because as our patients get older and they've had a lot of sports injuries in their lifetime, sometimes folks go on to getting knee arthritis. And so I wanted to talk a little bit today about what knee arthritis is and what are the treatment options for staying in the game. So arthritis is inflammation in one or more of your joints. There's more than 100 different types of arthritis, but osteoarthritis is the most common. So that's a wear and tear type arthritis that we see in folks over time. Other types of arthritis can be rheumatoid arthritis or post-traumatic, meaning you've had some injury and then you get arthritis. But osteoarthritis, or the wear and tear, is the most common type. So although there's no cure, there are many treatment options available to help manage pain and keep people active. That's what we want. People doing the activities they enjoy, enjoying life, and having good quality of life. So that's why we're here as orthopedists to help with that. And so here's some pictures of what knee arthritis can look like. And so what it is, the cartilage in the knee wears away. So the cartilage is at the joint, at the end of the bones. So this picture here is depicting the cartilage at the end of the thigh bone on the top and the shin bone on the bottom part of the joint, and then showing the wear of the arthritis and the wearing away of that cartilage. And over time, the space between the bones narrows. So then those bones start to rub and touch because they've lost their protective cartilage coating. And when that happens, creates a lot of pain, stiffness. The bone rubbing on the bone can be very, very painful. There's lots of little nerve endings in that bone right underneath the cartilage. So it usually develops slowly and can get worse over time. So as we said, the joint may become stiff and swollen, making it difficult to bend and straighten the knee. And this swelling and pain may be worse in the morning or after sitting or resting. It can be worse at the end of the day after a lot of activity. And vigorous activity may cause that pain to flare up. Get inflammation in the joint lining, the lining that keeps the knee joint in place and keeps the fluid inside the knee is very sensitive tissue. It's like the lining of your eye, and that when that knee gets inflamed, the inside of that joint lining can get red and can water just like your eye does as it's trying to flush out that irritation. And so you may see swelling in the knee. You may see some inflammation and warmth to the knee. And then these loose fragments of cartilage, as they start to wear away and break away from the bone, can interfere with the smooth motion of the joint. So some patients experience a locking or catching sensation. They may feel the knee creak or snap. They feel a grinding sensation in there. These are all things that we notice as you lose that smooth cartilage coating. And so it may cause a feeling of weakness or buckling to the knee when you get these sharp pains. It can make that thigh muscle, that quadriceps muscle, shut down and makes the knee feel like you're going to give out. That's a pain reflex. So the other thing that patients will mention is that it changes with the weather. So as if there's a storm coming in or changes to barometric pressure, Sometimes people can feel it in the knee. I think it has something to do with the fluid in the knee and feeling that change and that sensitivity to the changing pressure in the atmosphere. So here's what X-rays look like. So when we see a patient in our office, they have those symptoms, the first thing we're going to do is get an X-ray. And so I put up here a couple examples of what the normal X-rays look like versus what arthritis looks like on an X-ray. So on the X-ray, the top bone is called the femur, that's the thigh bone. The lower bone is called the tibia. And the space between those bones is where the cartilage lives. And when you lose that cartilage coating, those bones start to touch. So you lose that space. And then you start to see bone spurs, which are the little bony projections off to the side. And that's a way of your body responding to this new pressure to the bone by the bone actually growing or expanding. So it's trying to distribute that force, distribute that pressure. And so you get these bone spurs as a reaction to the increased pressure the bone is seeing because it's lost its normal cushion. So these are what we might see on an X-ray. So we know that about 20% of US adults are affected by arthritis. More than a third of adults over 60 have evidence of arthritis. So it's a natural process of the aging, the maturation process is the knee cartilage wears out over time. And so we're seeing for the first time in US history that older adults are projected to outnumber children. So we know that this problem is only going to get more and more prevalent, and there's going to be more and more need to treat this condition. So what are some of our options? Well, we do physical therapy, lifestyle modification. That could include either changing your activities, changing your diet, medications, injections, and surgery. So these are all the different treatment options that we'll go in and discussing here. So the first thing, the simplest thing is doing exercise and physical therapy. And you may think, well, my knee hurts, how can I exercise? Well, that's true, and that can be a difficult position to be in, but we need to get the inflammation and pain down so that exercise is possible, because that's really the best thing you can do for the health of your knee long term, staying active and staying fit. When we lose range of motion, put more pressure on certain parts of the knee because that force isn't being distributed evenly. We're overweight, putting more pressure on the knee. Every pound that you put on puts an extra 4 pounds of pressure through the knee. So that can add up and can create quite a bit of discomfort. This website I put on here in this little picture here is from orthoinfo.org. Now, this is a good website. This is put together by the Academy of Orthopedic Surgeons. So it's good information. It's not just Dr. Google or whoever is out there putting information out there. This is information coming from surgeons for patients, and they have these exercise packets for any condition you may have, knee arthritis, shoulder pain, ankle, wrist, whatever. And you can get some information and also get some rehab exercises to do to start trying to get more information and some treatment to get some help, even before coming to see the doctor. We're going to talk a little bit about medications here. So that bottom panel was a quick Google search of knee joint supplements. Boy, they put a lot out there. Or medications, you know, you could take Tylenol, though that's not an anti-inflammatory, but for certain patients with other medicines that prevent them from being able to take anti-inflammatories, sometimes Tylenol is a good first place to start. But typically the anti-inflammatories or non-steroidal anti-inflammatories or NSAIDs are going to be the first line treatment. So there's over-the-counters like Aleve or Advil, which are going to reduce the inflammation in your body, reduce the inflammation in the joint, and thereby alleviate some pain. Doesn't change what's going on with the arthritis, just manages the symptoms. And there are other prescription ones that the doctors will provide, and those can be, like Celebrex is a brand, or Voltaren. There's all these different ones. There's even topical anti-inflammatories. That Voltaren gel just became an over-the-counter medicine, and that was oftentimes prescribed by me for patients that couldn't take anti-inflammatories by mouth. Either they have previous stomach problems, kidney problems, other medications that prevent them from being able to safely take anti-inflammatories. So this gel, Voltaren gel can help reduce pain and not have the side effects with taking oral medicine. Then there's all these different supplements. So some people, they prefer not to take medications, or they can't for whatever reason. They want to try some supplements. So things that I've found to be helpful and that my patients have told me about is turmeric. So that can be taken as a supplement or is in a powder, can be mixed with food. Green mussels. This was one that I did not know about in medical school, but I've had a number of patients tell me about this. Another supplement is a natural anti-inflammatory in these little shellfish that they create a capsule out of. And then the glucosamine chondroitin. So these are a lot of these supplements that you'll see marketed and sold. Unfortunately, none of the glucosamine chondroitin supplements have been shown to be any better than a placebo. So patients who say that it helps them, I don't discourage them, but no study has ever shown that it's of any more benefit than a placebo sugar pill. And none of these supplements are regulated by the FDA, so you don't know exactly what you're getting or in which amount. So I typically don't recommend those supplements. So what about injections? Well, we can do steroid injections. The cortisone is kind of a generic term for a steroid injection. There's many different types of cortisone, but they're all steroids. Different than Aleve and Advil in that they're true steroids, and they reduce inflammation. So when we give those injections, we usually mix the cortisone with a little bit of numbing medicine like lidocaine or Novocaine, which you get at the dentist, and we inject that into the knee. And so that numbing medicine starts working first, but the cortisone itself takes about 1 to 2 days to start working. And in general, these injections can last about 3 months. But sometimes it's less. Sometimes the pain comes back, and then we look at other alternatives. Now we try to limit this to 3 injections per year. I get a lot of patients coming in, they're concerned about cortisone, they've heard bad things, they heard that it's going to damage your joint. As long as they're used sparingly and spaced out appropriately, they're very safe and well tolerated. They're not going to cause any additional damage to your knee. There was one study that recently came out that compared cortisone injections to saline, or just saltwater injections, over a 2-year period. And they found in the cortisone group that the cartilage had thinned out by an additional millimeter versus the other side. But my argument is, were these people having less pain for those 2 years, and were they more active? And that's what caused the cartilage to wear an additional millimeter. And is that millimeter of wear even clinically meaningful? I think that cortisone is very safe, and if used properly, is a good way to manage knee arthritis symptoms. The other type of injection that we do is mouthful, viscosupplementation, or you may have heard of it as a gel injection or the rooster juice, right? So what these injections are these gel injections that are synthetic joint fluid. So I tell people it's like getting an oil change for your knee. In arthritis, oftentimes the knee fluid goes away and the knee is almost dried out and it's very stiff, and these bones are rubbing one against the other. And so these lubricating injections, which are based on hyaluronic acid, which is one of the building blocks of joint fluid, these are synthetic injections that can be put into the knee. These usually take a little bit longer to start working, and one injection you can get every 6 months. That's as often as insurance will allow. And there's been Some studies out there showing that these injections may not be as effective, so they're becoming less covered by insurance. It's still an option, but it doesn't always work for everybody. Certainly if you have, bone on bone arthritis where it's just very advanced, these are not going to be as effective. But when chosen for the right patient, we still use them and still find them to be effective. So, but patients are seeking alternatives. So as we do a search of these Google trends, so you see patients Googling total knee. From 2015 to the present, there's been a 40% increase over the last 5 years. Same thing with the searching for biologics. You may be asking what that means. We're going to get into that. So biologics, what is that treatment for knee arthritis? Or platelet-rich plasma. That's seen a 130% increase in searches over the last 5 years. And so what is platelet-rich plasma and how does that help in knee arthritis? Well, we're going to get into that now. Teach you guys a little bit about orthobiologics. So these are any naturally derived product that can be used towards the goal of improving healing during an orthopedic intervention, both in the clinic or the operating room. So bone grafting was the original biologic. So when patients have bad fractures, sometimes we have to add extra bone from another source to help the bone to heal. And then tissue grafts and tissue banks, these are all the original kind of orthobiologics. So there's the well-established on the left side, like the skin and meniscus grafts and bone and cartilage grafts, versus breaking new ground with stem cells and PRP. So these are things that we want to talk about today to get you kind of up to date on some of these newer therapies that are coming out. So biologics, such as platelet-rich plasma or PRP, and stem cell injections involve taking cells from your own body and re-injecting them into the painful joint. So these cells are not manipulated, they're just taken from your blood, concentrated in a centrifuge, which is a spinning machine, to separate out the red blood cells from the plasma and the platelets. So if you look at the picture on the bottom right, you can see that in the blood, once we've separated it out with a centrifuge, you get the red blood cell layer, you get the platelet-rich plasma, which is that buffy coat, and then the platelet-poor plasma. So the plasma is the clear part of your blood. And the platelets are the little cells that go to the site of injury. So when you get a cut, those are the first cells that go there and stop the bleeding and tell the body, hey, come heal this area, we've got an injury. So we're using your body's own healing capabilities, concentrating them and putting that in the knee as a way to reduce pain and inflammation. So it uses the component of your own blood injected in the knee, uses these growth factors, these anti-inflammatory factors to help reduce pain. What about stem cells? So PRP is technically not stem cells, although there are a few stem cells floating throughout the body in the blood. They're more concentrated in the bone marrow or in the fat, actually. And so stem cells are precursor cells that can be turned into other cells. And so they can be taken from certain sites in the body and injected back into the knee. And the theory is that they may help to heal damaged joint surfaces, but all the studies that have been done have shown they're mostly just a really good, strong, natural anti-inflammatory. None of these treatments are regrowing cartilage or making your knee, reverse in age. Once the cartilage is worn away, that's it. And even these new biologic treatments can't reverse time, unfortunately, but they are good at reducing pain. So here's an example of a process of PRP. So you get your blood drawn in the clinic. It's just a little vial of blood. We put it in the centrifuge, which spins it for about 10 minutes, separates out those layers, and then we extract some of the platelet-rich layer and some of the plasma and inject that into the knee. We don't take any of the red blood cells. And so that gets injected to the knee through a standard needle. Sometimes we use ultrasound, sometimes we don't. And this can be done in the shoulder, the knee, the hip, the elbow. It's been most studied for knee arthritis. It's most effective for knee arthritis and for tendonitis about the elbow. So tennis elbow is the other place where PRP has been shown in the literature to be strongly effective. So here's just some studies showing PRP and that it's successful. We won't go into detail here, but just there's been a lot of research done over the last decade plus showing that this is safe and effective for patients and actually does better than any of these gel injections or cortisone, even better for longer term pain relief, better pain relief, and is the patient's own natural substance. So PRP, it's safe and effective. Still not covered by insurance. So it becomes an out-of-pocket expense to the patients, and the price varies by institution. But I got to imagine at some point insurance is going to have to cover it because it's just too well studied, shown to be safe and effective, and it's going to become another treatment option like cortisone to help people with knee arthritis. And I think once it becomes covered by insurance, it'll become more widespread. Right now, the cost is kind of prohibitive for a lot of patients. All right, so we've done all that, but unfortunately, pain is still persisting. So now we got to talk about what surgery options are. And those are mostly going to be a knee arthroscopy or a cleanup or a knee replacement. So in knee arthroscopy, a camera is placed into the knee through 2 small incisions, but it has limited use in knee arthritis that's advanced. You know, we're going to clean up some meniscus tearing, so we're going to clean up some loose cartilage, and it may get rid of some of the catching, locking, and giving way, but in folks who have very bad arthritis, it's not going to relieve their pain. So really, this is used for folks who have minimal arthritis and have more what we call mechanical symptoms like the catching, locking, giving way. But in folks with bad arthritis, this is not going to be very helpful. So then we're talking about knee replacement. And so knee replacement can be a total knee replacement or a partial. And so the difference is, as you can see on these X-rays, where the partial is only, the metal is that bright white, is only on the one half of the knee, versus a total knee where the whole thing is replaced. And so I put on here these pictures just so you can see what these different components are that we put in. So there's a metal cap that goes on the end of the thigh bone. There's a metal tray that goes into the shin bone. And then a plastic spacer that snaps into that tibial tray there. And that's the joint replacement. And then we put a little plastic button on the undersurface of the kneecap. So that's how the joint replacement is done. And so that is a 1 to 2 hour surgery. It can be done as an outpatient now. And so we've gotten better with improved pain control and these pain pumps that we use to keep people's pain manageable. And so in the right patient, these can be done outpatient. You can go home, same day. You're able to put weight on these right away because they get cemented in. They're very sturdy, but it is a several month recovery. You know, you're going to be looking at physical therapy, and that's very important to the success. You know, it's just as important as the surgery itself, getting that motion back, getting the range of motion back, the strength back. Very important. Typically, I tell patients it's going to be about 6 weeks. You're going to feel about 70% of the way there. By 3 months, you should feel about 85% better. 9 months, about 90 to 95% better. But it can be a whole year before it's as good as it's going to be. So I wanted to also touch briefly on some of the advancements in knee replacement that you may have heard of out there. Things that are marketed heavily towards patients. One of those being the robotic assisted total knee. So there have been many companies that have developed this technology to assist surgeons in the operating room to do knee replacement more accurately. So these computer systems guide the patient, guide the surgeon's hand, surgeon still doing the procedure, but the computer guides your hand where to remove the bone so you can do it more accurately. Now, they've been studying this for the last 10 years, and there haven't been any benefits shown to this as far as improving patient outcomes. So despite all this fancy technology, the good old-fashioned knee replacement is still performing just as well as the robotic assisted. Yes, the cuts may be a degree or two more accurate with the robot, but it's not translating into better patient outcomes. Patients are still doing well with both and doing the same with both operations. So there's, like I said, a few different systems developed here. And so what it is when you're in the surgery, we put this little probe on the bone, and that talks to these computer towers, which makes a map of your knee. And then the software puts on the implants, those green and blue, that kind of the fake knee replacement parts, onto the map of your knee. And then that robotic arm, which attaches to the bed, the surgeon holds it, and that arm guides you to make those, remove that bone as it is with the plan developed by the computer. Hold on, my light went out. Sorry about that. Okay, so that's kind of what the computer or robotic assisted joint replacements are all about. And again, it's very exciting technology. It can help things, be a little more accurate, but in a well-trained surgeon's hands, the accuracy is not that much better with these, and the outcomes are the same. So although these are exciting technologies and are certainly used for a lot of marketing purposes, they haven't shown to be superior to just a traditional knee replacement. Which brings me into the last point that I wanted to talk about, which was minimally invasive, because I also have a lot of patients coming in asking about minimally invasive surgery. What does this mean? So this is a knee replacement done through a shorter incision. So the incision is a couple inches shorter than a traditional knee replacement, but it's all the same parts going in. It's all the same bone. We got to remove bone and put metal and plastic in. So in the end, it's not really that different. Again, I think it's mostly a marketing tool that some surgeons use to promote their practice, which is fine. But not all patients are a candidate. It's still the same joint replacement that you're getting. And the long-term benefits of minimally invasive surgery do not differ from traditional approach. So all these things that you hear about, minimally invasive and robotic assisted, are great and exciting, and more studies going to be done, but we're not seeing any difference in patient outcomes with these technologies. So that's all I had. I wanted to give plenty of time here to open it up for questions. This is my contact information. Happy to answer any questions that you have. Melissa has my contact info. Happy to connect anyway.
Yes, anybody can. Thank you, doctor. And yes, you're all welcome to call the office, or you have the phone number right here. And I am going to stop the recording now.
All right.